Hi, this is Roger Green, host of the Surfing the NASH Tsunami podcast. This weekend, we are offering 6 conversations from Season 3, Episode 27, our wrap-up of the 5th Global NASH Congress that took place in London on May 27th and 28th. This conversation includes Louise's interview with Rick Grobbee of Julius Clinical. At the conference, Julius Clinical discussed its GRIP program, an effort to conduct 10,000 VCTE tests with individuals in primary care offices, currently targeted for 1,000 individuals in 10 European countries each. The study will determine prevalence of NAFLD and NASH in these primary care populations, while assessing the impact of the guidelines Julius is using to bring patients into the study. This conversation covers the scope and goals of the project, along with the need to find more patients for clinical trials, and the parallel need to create guidelines that make medical and economic sense in primary care practices, at least in the major European countries. The 5th Global NASH Congress brought together industry, academic, and patient advocates in a forum that covered an array of issues and perspectives. We've tried to bring you an assortment of these in the Episode 27 conversations. So sit back, listen, enjoy, learn, and when you're done, join the dialogue on our LinkedIn discussion group.
Louise Campbell.
We're going to speak about the GRIP program. If you can introduce yourself for me and just tell me a little about what you do and what the GRIP program's all about.
Julius Clinical Chief Scientific Officer Rick Grobbee.
Yeah, I'm not a NASH expert, but I've been working for decades in the cardiometabolic space, so it does rhyme. I've been trialing with new medication in diabetics and hypertensive patients and patients with acute coronary syndrome. And these are overlapping phenotypes, there's no doubt. So when NASH came on, I immediately became intrigued because it turned out to be somewhat of a separate pathophysiology, but not entirely, and clearly an emerging problem, increasing rates of obesity and diabetes and so on. But then very much in the hands of hepatologists and gastroenterologists, and focusing very much on the liver, whereas if you look at what happens to these patients, their greatest risk is probably not hepatocellular carcinoma, but it's getting a stroke or a heart attack. So that sort of attracted me to this problem. And then we started building within our company, which, as I said, is an academic spin-off. We started building expertise, assembling our advisors around us, and increasingly felt that major improvements could be made in finding those patients by reaching further out in the community. So what GRIP on NASH tries to do is to get grip on that number of patients that's just under the water currently, because they are being taken care of by GPs and not necessarily recognizing that there is more than their diabetes, or there's more than their hypertension or their hyperlipidemia or their kidney disease, and just not aware of the nature and size of the problem. So bridging those two worlds by bringing centers of excellence with real expertise in contact with GPs surrounding them and trying to find new pathways of targeting the right patients. Underway learning about diagnostics and improvements thereof. As we spoke yesterday briefly, so we're collecting loads of material just to be prepared for the next wave of metabolomics or epigenetics that might help to sort out not only the diagnosis but also subphenotypes, because it's probably, as always, as diabetes, as heart failure, a heterogeneous group of patients with different subphenotypes that might respond different, have different prognoses and different comorbidities. So it's a learning exercise. At the same time, it's also a way of finding patients for intervention research.
So can you just describe the format of GRIP? Because it appears to be based on guidelines and that interpretation of implementation,
Yes.
which, whilst guidelines are written, they're often not implemented.
No. And that's because routine care is not necessarily equipped to implement. In this case, it's different because we are designing a GRIP on NASH and supporting that also financially to follow the guidelines. Mm-hmm. The only thing we've done, as I've shown, is that we bypassed the step between FibroScan and FibroScan. So they combined that just to have, in spite of the comment that was being made that there may be misclassification, yeah, true, but we feel it's less likely with FibroScan than with the conventional pathway. In the conventional pathway, biochemistry comes first, 5% comes next, mainly for implementation reasons. Mm-hmm. Because biochemistry is could be in the hands of GPs or general internists, FibroScan not. Also because of cost, because, sending anyone to FibroScan is raising costs. So we sort of took care of that. So we've simplified the guideline, the pathway, but we're also enforcing its implementation.
I think that's certainly somewhere that I've talked about on the podcast. If you find a liver at risk, you can do a blood test. If you find a blood test that's normal, you don't tend to find a liver at risk.
Yes.
And I think that's the opposite paradigm. And if you don't find the liver at risk, you don't find the cardiovascular problem, the diabetes. There are benefits to cutting out FIB4 en masse And you can do the cost effectivity of that as to how much they're fit for.
Yes.
Everybody says it's free, but every blood test costs.
True. So we've not sort of bothered to see if we could motivate the population at large for specialists to do this, but we simply implement that in a limited number of sites. So initially, as I showed, in a couple of countries, 1 or 2 sites per country, and all of these are sites that, on the one hand, have the knowledge to manage these patients and interpret their findings, but also are able to tap into the region for the GPs.
Are you taking feedback from the GPs how they find it? Was it more difficult? Because one of the concerns, certainly that always gets raised in the UK, is if I screen and find it, I've got to pay for it, and where's the money coming from? If I don't screen and don't find, I don't pay any money. But they avoid the cost that they are paying in their diabetes, their cardiovascular, so that the costs are just hidden in a different way. Obviously, it's intrinsic that primary care take this on, as that's where most of the poor liver health is.
Yeah, that's true. So it's something we need to be aware of, and we are aware of that. So primary care physicians have been involved in the design. Mm-hmm. So it's not top-down specialist-driven, but they took part and take part in discussions, and we will monitor along the way what their experiences are. So we're currently taking care of those costs that would otherwise also not be generated in routine care. So the costs that would fit into reimbursement schemes, and these may even vary across countries, they'll stay where they are. Anything else, we will reimburse to at least for the moment, not make that an issue, but we of course need to see how it works out eventually in terms of overall cost benefit.
And does this potentially mean that patients located with clinical trial inclusion criteria will be able to go straight from primary care potentially into clinical trials? Because at the moment, obviously, that isn't the case. They have to go through this whole rigmarole.
Yes.
So that opens up clinical trials like Donacry, GLI, ELPA talk about getting people with poor livers to clinical trials quicker.
Exactly. Currently, there's really, like, if you wish, an elite or a select group that reaches that. Yep. It's full of hurdles. So we need to take some of these out, realizing that the bulk of patients will be in the general population, unrecognized. So effective, affordable, credible tools to get to those patients directly is really going to help the development of the drugs enormously.
And are you collecting patient-related outcomes?
Yes, we have the Liver Patient Association.
Mm-hmm. European Liver Patient Association.
Yes, that's it.
With Marco and that.
Yes, exactly. So they've endorsed this program. They will be our sparring partners. They also judge the protocols, and any material that we develop is going to pass their desk to have to input on it. And in the patients, we're going to collect prompts for just to see how patients value this whole trajectory.
One of the good questions to potentially add in, if you haven't, is what made you change your behaviour?
Yes.
Because I think you'll find a lot of people change their behaviour because they see their FibroScan or because they don't respond to blood tests.
No, they don't know. And in fact, I'm from a different field. And for example, I've developed over the years different non-invasive imaging modalities for cardiac disease and vascular disease. And there too, people will not respond to a lipid value. No. But if they see a plaque in the carotid, it becomes a different story. So in that sense, imaging may help to motivate and make people compliant. We'll monitor that because, as shown, there's a couple of months in between the first and the second FibroScan in which they refer back to the GP for lifestyle measures. So we'll see what happens, and we'll ask patients what they think about this. So that is not a randomized comparison with or without imaging, which would also be interesting, I believe, but it's a different question to ask.
Will you be looking at how many of those patients have online access to digital apps? Because sometimes that's the motivator. If they've got an app on their phone that talks about their nutrition and their diet, that's often more useful to a patient or a person than a GP. So you're getting different information. So collating what information that person is getting can change the outcome.
Well, it's a good point. Might easily insert it into our questionnaire whether they have access to that. We're not going to actively promote that. It's beyond the scope of the project. But we'll just put it in the questionnaire.
Because these are patients or people who are going to be invested in their own health. And people who are invested in their own health statistically use health apps more, even if it's noon or...
Yeah, although, knowing the type of patient, I don't think that's perhaps the most health literate
That's
population.
true. They're high risk, aren't they?
Yeah, they wouldn't have come this far.
Stephen Harrison says the low-hanging fruit.
Well, yeah, but they're therefore very difficult to change behavior. In our experience with diabetic patients, overweight patients, they typically don't even consider themselves overweight.
So is one of the outcomes really to also enrich the knowledge in primary care of who they should be screening?
Yeah.
Because that means everybody gets screened.
Yes,
and
it's an important
without
element.
doing a direct.
Yeah, sure. So it's not really focused on patient awareness, but for sure on primary care awareness.
And the nurses are often the people who,
yes, of
the
course, in
diabetic
practice,
nurse or the practice nurse.
So the practice nurses should be part of this whole scheme. There's also like educational programs envisioned for GPs and their practice staff to get them up and running for the screening. So yeah, I'm sure that some of the learnings will benefit the primary care community.
Absolutely. And from my perspective, now more into liver wellness and that, I think it's exciting, and I'm waiting to see the results, obviously several years down the line.
Yeah.
Because I think that's where poor liver health sits. Yes, there's a low-hanging fruit for NASH and NAFLD, so it'll be really interesting to see what the diagnosis levels of NASH or just inflammation.
Yeah, so we'll see what dominates. It might be an entirely different spectrum if you have this source. So it will clearly show what the real face of NASH in the real world is. At least I hope so. And it will also, therefore, potentially change the nature of intervention strategies, because, again, I think that for the bulk of NASH patients, the biggest risk is not a decompensated liver eventually, but all that comes along with it.
But also you're putting FibroScan where I think, personally, FibroScan should be before specialist. It's an assessment of anybody who could have poor liver health.
Yes.
It's not a liver assessment for only liver patients, because we all have a liver. I'm excited. I think the programme, the way it's been designed, has got lots of benefits.
Yeah.
There was a question raised, obviously, about the risks of people who've just on FibroScan, but I think some of the benefits for me are those who just have soft fatty livers, who find out more about their cardiometabolic problems.
Exactly.
And the improvements in HbA1c and the way they're managed in primary care, which I don't think has ever been done.
No,
it's exciting.
Thanks a lot. We feel too. So let's see what it brings us. We're certainly going to do it. We have enthusiasm from major centers in the countries that we listed, and the data will be generated.
And I think if it enriches the trial space with patients to go directly to the trials to get their biopsies, which are still required a lot sooner than it progresses, it's got lots of benefits.
Because it's a bit sobering that there's going to be potential interventions, be it old as I showed or new ones, but there's a shortage of patients to be studied. That is really impressive. While there's many patients out there.
The pandemics affect all of the lists for FibroScan. There's a year waiting list in some trusts, if not longer, so where it's limited. But no, thank you for your time.
Most welcome.
And good luck with the programme.
Yeah, thanks a lot.
And now, back to Roger.
We hope you've enjoyed this recording. If you have any questions or comments about the content of this conversation or the entire episode, please send an email to questions@surfingnash.com. We will be back next week to preview International NASH Day. Until then, stay safe, surf on, and we'll see you on the podcast. Bye-bye now.